Hi friends, welcome once again to Relay Tutorials. Sorry we got a bit delayed this time because I was not keeping well. The topic for today's video is PCOS or polycystic ovarian syndrome, and let's not get used to it. These days, many young girls are suffering from PCOS. It is very common to find at least 2 to 3 patients out of 10 patients in your OPD who come with the complaints suggestive of PCOS. It is not merely an endocrine disorder that affects young women and women of reproductive age group, but a harbinger of something as serious as metabolic syndrome. Majorly hyperandrogenism, which leads to increased facial hair growth, thick voice, and infertility are distressing to young women, but its metabolic sequelae eventually affect the women in terms of serious chronic illnesses. It is imperative not only to recognize but also to reverse or arrest its metabolic sequelae. It requires awareness to get screened for the expected complications that may allow proper and timely management. So we need to catch it really early. Looking at the history behind PCOS, Vallisneri was the first person to give histological description of the polycystic ovary way back in 1721. Steiner Leventhal described the features of 7 hirsute amenorrheic women based on the characteristic ovarian morphology from histological specimens taken at wedge resection of the ovaries in 1935. So paper on these 75 women who underwent bilateral wedge resections, nearly 90% of whom began to have spontaneous menstrual cycles and 65% of those seeking fertility conceived. So this was published by Stein, Cohen and Alson in 1948. How do we define PCOS? ESHRE, that is European Society of Human Reproduction and Embryology, and American Society of Reproductive Medicine had a common consensus which defined the criteria of PCOS in 2003, also known as Rotterdam criteria. It requires the presence of 2 out of the following 3 criteria: oligo or anovulation, hyperandrogenism, the signs could be clinical or biochemical evidence, polycystic ovaries on ultrasound, that is more than 12 follicles of size 2 to 9 mm, or ovarian volume more than 10 mm cube. So we basically deal with menstrual cycle, ultrasound report and the androgen effect. PCOS, if we look into the epidemiology, it affects 5 to 10% of women of reproductive age. Its prevalence among women facing subfertility or infertility is around 15 to 20%. It is often seen in the young girls, but majority of them are left untreated, which later are diagnosed when a woman presents with infertility post-marriage. So that is the most common complaint they come up with in their adult life. If we look into the genetics of PCOS, it's a very complex genetic trait. While the precise mode of inheritance is still uncertain, a familial basis for the syndrome is well established, and it is not uncommon to find a mother or a sister with 1 or more symptoms of PCOS. Etiopathogenesis, again, it still remains unclear. It is, as I said, a complex genetic trait which interacts with other congenital or cellular environmental factors. There is definitely a role of insulin resistance which is being suggested, and it is being proved by some of these studies. What we know so far is there is an inherited insulin resistance. So there is compensatory hyperinsulinemia, that is elevated fasting insulin levels, which causes increased androgen production, which in turn inhibits follicle development and prevents ovulation. And that is why we get these chronic anovulation picture called as polycystic ovarian syndrome, where there are development of multiple small follicles that do not ovulate. There could be a little bit of genetic predisposition to excess ovarian androgen secretion and insulin resistance. They together play a major role. I think if you'll carefully look into this diagram, a lot of things would get clear in your mind. Clinical hyperandrogenism can present as some of the very irritating symptoms to any woman. Acne, increased sebum production or seborrhea, male pattern balding, Hirsutism. increased muscle mass, deepening of your voice, and in few rare cases, even clitoromegaly has been reported. Hirsutism is nothing but excessive hair growth on a woman in places usually seen on men, such as the face, chest, back, and abdomen. The areas which we generally examine are upper lip, chin, chest, upper back, lower back, upper abdomen, upper arm, forearm, thigh, and legs. So there is a Ferryman-Galway model scoring system for the severity of hirsutism. Generally, the modified FG score more than 6 or equals to 6 is defined as hirsutism. Acne, again, every woman's nightmare. It can be seen in approximately 1/3 or more of PCOS patients. Androgen excess has been associated with acne. The areas of your face that are likely affected with acne are the lower half of the face, cheeks, jawline, chin, and upper neck. Androgenic alopecia is progressive, non-scarring, patent loss of scalp terminal hair, commonly underdiagnosed but can be really concerning. Acanthosis nigricans. These are the mucocutaneous eruption characterized by hyperkeratosis, papillomatosis, and increased pigmentation. Just look at this picture. You can find girls coming with such kind of pigmentation in your routine OPD. Velvety plaques on the nape of the neck and intertriginous areas. They generally occur in axillae, nape of neck, under the breast, and flexures. PCOS patients have benign Acanthosis nigricans, and it is associated with insulin resistance. Now we'll come to the serious picture which I said in the beginning of the video, the metabolic syndrome and PCOS correlation. The prevalence of metabolic syndrome is as high as 33%, that is almost 1/3 patients with PCOS, and it is associated with long-term consequences like cardiovascular disease, diabetes mellitus type 2, some of the cancers, sleep apnea syndrome, and psychological problems. Earlier management of PCOS has focused on infertility, anovulation, and hirsutism. But due to enormity of the health burden of metabolic syndrome, it now deserves focus on accurate identification and timely intervention. Insulin resistance is said to be the main culprit so far. It is commonly, though not universally, found in PCOS, with prevalence being estimated in 50 to 70% of the cases. And see how this insulin resistance can lead to type 2 diabetes, PCOS, atherosclerosis, dyslipidemia, and hypertension. So as we see the long-term risks associated with PCOS, if you combine this lifestyle, which has completely been changed these days, many of us are into junk food, sedentary lifestyle. We don't get up from our bed, especially the young brigade is hooked to the gadgets, either to their cell phones or their iPads or TV screens, LEDs. So this kind of lifestyle with some undercurrent of genetics is leading to obesity and hormonal changes, which further is a reason for increased levels of androgens and insulin, leading to anovulation, leading to multiple unruptured follicles in your ovaries, and which further lead to all the disorders which we just went through in our previous slides. Obesity in PCOS, it most likely results from the combined effect of genetic predisposition, poor diet, and a sedentary lifestyle, thus compounding pre-existing metabolic derangements. Hyperandrogenemia increases a person's predilection for central adiposity and worsens insulin resistance and dyslipidemia. And there is impaired glucose tolerance and diabetes mellitus in these patients. Women with PCOS with baseline normoglycemia, as in normal sugar levels, have a more pronounced risk of developing impaired glucose tolerance, and up to 16% of women with PCOS convert to IGT per year. And women with baseline impaired glucose tolerance have a 2% risk of progressing to diabetes type 2 per year. And over 6 years, this risk may be as high as 54%, and that's a big number, and one must take it very seriously. Cardiovascular risk in PCOS. One meta-analysis demonstrated that in women with PCOS, the risk of coronary heart disease and stroke is doubled 2 times. Despite adjusting for BMI or body mass index, there was a 55% increase in the risk. A similar study using coronary artery calcification as risk stratification has shown increased risk in patients with PCOS, and these are all published data in international index journals. Sleep apnea. It is not something just to mock about. It is a serious disorder, sleep apnea. PCOS is associated with up to 30-fold higher risk of obstructive sleep apnea and a 9-fold increase in excessive daytime sleepiness. Insulin resistance has emerged as a principal predictor for the risk of obstructive sleep apnea, independent of elevated testosterone levels and obesity. Women should be screened for and counseled about snoring, daytime somnolence, and fatigue. Psychological issues may hit PCOS patients. The prevalence of depression is higher in PCOS women than general population. With increased severity of symptoms, this association is independent of BMI. They are more likely to develop anxiety, eating disorders, and dysfunctional relationships. So please start to take it seriously. PCOS, infertility, cancers, all of this sounds scary. PCOS implies oligo or anovulatory cycles, as we've been talking about since beginning, which is directly linked to subfertility and infertility. When there is no ovulation, obviously patient will face difficulty in conceiving. The hyperestrogenism, that is high levels of estrogen associated with PCOS, is linked to increased likelihood of endometrial cancer, that is cancer of uterus. Pregnancy in PCOS, like if a PCOS patient conceives spontaneously or with some treatment, there is an increased risk of gestational diabetes mellitus, gestational hypertension, and later on even preeclampsia. There is increased risk of miscarriages, especially in first trimester, chances of preterm labor, macrosomia, higher incidence of cesarean section, and then the morbidity related to it. So basically, the pregnancy becomes a high-risk pregnancy. It's high time that we catch this disease very early, we become more aware about PCOS, and we have dedicated a month, September, as PCOS Awareness Month. So I want our young girls and women to go through this video and understand the fact that the PCOS is not just about delayed cycles or slightly irregular periods or scanty periods. It is much more beyond that. It's an early warning, it's an early alarm which we all should take very seriously. And how to beat PCOS or how to manage PCOS, we would be watching that in our next upcoming video. Thank you for watching Relay Tutorials. Take care, like it, subscribe it. Bye-bye.